Let's be honest, an acute asthma attack in a child, it's one of the most stressful situations you can face as a healthcare professional. Every single second counts, and knowing the right steps to take isn't just important, it's absolutely critical. So today, we're going to dive into this and break down the official guidelines into a clear, actionable protocol you can use.
So, picture the scene. A child is struggling for every breath. You can hear that classic wheeze, and their parents are looking right at you, desperate for answers. In that moment, what's your first move? What is the protocol?
Well, thankfully, we don't have to guess. The answers are all laid out for us in clinical guidelines, just like this one. But these documents can be, they can be dense. So our goal here is simple. We're going to pull out the most essential info and make it super easy to remember when you need it most.
And that brings us to the most critical first step of all, assessment. Before you do anything else, before you reach for any medication, you have to gauge the severity of the attack. Seriously, every single decision you make from here on out flows directly from this one initial judgment.
Okay, take a look at this. This table is basically your roadmap. It simplifies that whole assessment process. Just look at the differences in speech. A child having a moderate attack, they can still speak in full sentences, but if it's severe, they're down to just a few words or phrases. And if it's life-threatening, they might be completely silent. And notice those other critical signs. The oxygen saturation, or SpO2, drops, and the heart rate flips from way too fast, tachycardia, to dangerously slow, which is bradycardia. These are the signals you've got to be looking for.
And hey, just a quick word on SpO2. Think of this number, your oxygen saturation, as a direct window into how well the lungs are doing their job. It's like a fuel gauge for oxygen in the blood. So when that number dips below 92%, that's a major red flag that the body just isn't getting the oxygen it desperately needs.
All right, so you've assessed the situation, and you've determined it's a moderate attack. This is probably going to be the most common scenario you face. So let's walk through the first-line response. What do you do?
The protocol here is crystal clear. It's a three-step game plan. First, get them on high-flow oxygen. We're aiming for that sweet spot, an oxygen saturation between 94 and 98%. Second, it's time for salbutamol. That's 10 puffs using a spacer, and you can repeat that every 20 minutes. And third, you're going to give them oral prednisolone, which is a steroid, and the dose is based on their age. Easy as 1, 2, 3.
So what's salbutamol actually doing in there? Well, think of it as the first responder, the rescue medication. It's a bronchodilator. That's a fancy way of saying it gets to work super fast, relaxing all those tight muscles around the airways, and boom, opens them up so air can finally get through. It's all about that immediate relief.
And what about prednisolone? This is the other half of the 1-2 punch. It's a steroid, and its job is to tackle the root cause, the inflammation. Now, it's not going to work in seconds like salbutamol does, but it's absolutely essential for calming the whole system down over the next few hours and, really importantly, preventing that attack from just coming right back.
Okay, but what happens when your assessment points to something much more serious? When you're dealing with a severe or life-threatening attack, we don't just throw out the old plan. We escalate it. We build on those initial steps, but we get way more aggressive with our interventions.
This slide shows that escalation perfectly. See the key changes for a severe attack? We ditch the spacer and move up to a nebulizer to deliver that salbutamol. We also add a second airway opening drug, ipratropium bromide, for a much more powerful effect. And if the child can't take steroids by mouth, we're ready to go straight to an IV. So if we look at the whole protocol for a severe attack, you can see how we're turning up the dial. Oxygen is still number one. That never changes. But now we're hitting them with back-to-back nebulizers with 2 different drugs. We've got the option for IV steroids, and we start considering some real heavy hitters, IV medications like magnesium sulfate if the child isn't getting better. And crucially, we're monitoring way more closely, and we're already thinking about getting them to the pediatric ICU, or PICU.
So why do we add ipratropium bromide into the mix? It really is all about teamwork. See, salbutamol and ipratropium are both bronchodilators, but they work on completely different pathways in the airways. So by using them together, we're basically attacking the problem from 2 different angles at once, and that creates a much, much stronger airway opening effect.
Let's just pause on this for a second. This quote really gets to the absolute heart of everything. Recognize the severity of the attack and start treatment promptly. That's it. Every single thing we've talked about flows from this one simple principle. That first assessment you make dictates everything that comes next.
All right, now for the most critical scenario, a life-threatening attack. Here, there is zero hesitation. Step 1 is high-flow oxygen and an immediate call to the PICU. The nebulizers are now running continuously. Those IV meds, like steroids and magnesium, we're not considering them anymore. We're giving them right away. This is an all-hands-on-deck emergency, and it requires constant, intensive monitoring. And what's the deal with that IV magnesium sulfate? Think of this as a powerful tool we save for the really severe cases. It's a smooth muscle relaxant, so when those airways are clamped down so tight that even the nebulizers are struggling to get in, IV mag can help relax those muscles from the inside out, giving us that extra vital bit of airway opening we need.
Whew! Okay, we've covered a ton of ground here, right? We've gone from basic assessment all the way to IV drips. So let's bring it all home. Let's distill this down into the core principles you absolutely have to remember.
So, if you walk away with anything from this, let it be these 5 key takeaways. 1. Assess first, always. Your whole plan depends on it. 2. Oxygen is key. It is never the wrong first move. 3. Escalate logically. The treatments are tiered. They build on each other. 4. Don't delay steroids. They fight the fire of inflammation. And finally, number 5, know when to call for help. An early call to the PICU literally saves lives.
At the end of the day, the guidelines give us an incredibly clear and effective roadmap for handling this kind of emergency. The steps make sense, the evidence is there. The only question left is the one you have to ask yourself and your colleagues. The protocol is clear. Is your team ready?